Good afternoon. Please continue eating and talking at your tables. I'm Ferris Taylor, the Executive Director of the Healthcare Executive Group, and we've, with the support of Appian, who's one of our 10 sponsoring organizations, have put this opportunity together to have a conversation around a topic that over my 30 years in healthcare and probably things that each of you have observed addresses one of the challenges that I think we are struggling with in terms of leadership and innovation. So we want to welcome you here. We're not going to start the panel until lunch is kind of wound down. So don't stop. But I wanted to introduce ourselves, and I will give Kate McConnell just a minute to thank her for the sponsorship. I also want to thank the Center for Healthcare Innovation, WEDI, the work groups on electronic data. What's the I, Charles? Interface? Exchange? Interface. And the International Association of Innovation Professionals. It's interesting, and this group of associations came together last year at Health, which was the first Health conference. And it came together because as partner associations with Health, they had given each of us an hour's time to have an association meeting. And I looked at the agenda and was thinking about what we could do and reached out to Charles and to Joey and Lynn at the Center, CHI, and to Brett Trusco at IAOIP, said, what are you going to do? They said, well, we don't know what to do. And I said, well, let's get together and see if we can address a healthcare issue that will help move the industry forward. So thanks to HCEG and the other three associations for joining us in this opportunity. As background, the Healthcare Executive Group is actually 31 years old. We were formed in 1988 when, and I see some gray hair, some of you will remember this organization, Digital Equipment, or DEC, the mini computer manufacturer, disbanded their healthcare users group. And that group of users said, independent of DEC, we find value in coming together and sharing perspectives on the challenges in healthcare, the priorities, the issues that have to be addressed, and then having a network across the country where we can pick up the phone and call each other, typically non-competitive competitors talking, and say, I've got this challenge, do you have that challenge? If you don't have that challenge, maybe there's something wrong in my organization, or vice versa. So we have been facilitating that networking and that thought leadership and that exchange of ideas for 31, soon to be 32 years. Part of our process, and this got more formalized about 15 years ago, after a year of discussions back and forth, webinars and roundtable discussions like this, our annual meeting, we would actually publish or go through and create our own David Letterman top 10. And every year it's a different top 10. So for the current year, in our webinars and our blogs, our white papers, our sponsors all address these issues. This is the top 10 list. And you can actually see 10 or 12 years of this top 10 list by going to our website at hceg.org. And they change every year. This happens to be our top 10 list for 2020. We will really kick this off in December. But the common element across both of these lists isn't a topic. It's an issue where there's an intersection of the challenges of trust in healthcare, not just our members or our patients and their trust of us, and there's been a lot of conversations at Health around the issue of trust, but there's an intersection of trust and how as organizations we create the culture within our organization of leadership. But more importantly, those factors then impact a really interesting topic that's also been talked about, which is innovation. And we have one of our panelists that will actually challenge that to take it to radical innovation, has written a book, and we'll get to the introductions on that. But the theme for today is really that leadership and innovation challenge across, whether it's the 2019 list or the 2020 list or any other list that we come up with. So I'm going to give Kate a few minutes, thank her. She provided the lunch. She's one of our long-term sponsors. And then setting at your tables. Oh, are we out of tables? Okay, they're going to bring some more tables. Keep coming, get your lunch. I'm going to leave this slide up because we've asked the panelists to actually be scattered around your tables. And they're there to really put an ear to the ground as to why you're here and what you want to hear about. So you can influence their panel perspectives after we finish the lunch. So after Kate, and thank you Kate and Appian for supporting us on this, after Kate introduces us to Appian, we'll continue lunch, and when we see it winding down, our moderator, Charles Stellar from WEDI, will come up and kick off the panel this afternoon. Kate?
Thank you, Ferris, and thank you to Juliana and Steve and the other folks from HCEG who made this possible. And I also want to thank in advance today's panel. I think it's going to be a terrific panel discussion on innovation, which we've all been soaking in the last 2 or 3 days. So my name is Kate McConnell. I'm the industry leader for healthcare health plans at Appian. You have probably never heard of Appian. We're probably the most successful company that's been around for 20 years that you have never heard of. So this is the one commercial during today's presentation. So Appian is a platform for digital transformation. Appian, when you build an application in Appian, you do not code it, you draw it like a flow chart. That's a new approach in software development, and it's called low code. We're a pioneer in that area, a leading company in that area, and Forrester Research says low-code development can be done in 10 to 20 times faster than traditional development using Java and other technologies. So think of Appian if you have a business problem that requires you to span 2 or more systems to do a new thing, or if your business has a problem for which there is no existing technology and your business users are building things out of Excel and Access and Outlook and heaven knows what else, right? Things that can't be supported. So Appian is proud to sponsor HCEG. We sit on the board. In terms of the top 10, we typically play in the digital transformation and customer experience areas. So think of us in that area. And at your tables, we have 2 other folks from Appian. We have John Roche, who is one of our account directors out of the Boston area, and Alexa Cushman, who is our industry marketing leader for healthcare. And we really appreciate them coming today. So thanks again, Ferris. Where is Ferris? I'm going to give you the mic back. Okay, fantastic. Thank you. And everyone enjoy your lunch. I think we still have some seats down front if people are looking for places to sit. I know there's a place there, there's a place there. Please make yourself comfortable.
Good afternoon. Oops, a little loud. It's my pleasure to ask our panelists to please join us on the stage. We want to recognize that you're still eating, and please do so. But at the same time, we're aware that there may be people who are trying to make flights, so we certainly don't want to, we want to get started. So with that, we'll have the lineup as you see it to my left and right. We're going to have Lynn, and then Sunnie, and then Jason, and then Giles is here, right here, and she'll be joining us in just a second.
Oh, Sunnie. Never got it right. She didn't get mic'd up.
Oh, her, okay. Great. So we've heard, Ferris has described what we are here today to address. Now, we're set up in this arrangement so that we can have the dialogue with the panelists. This is supposed to be an interactive system, a situation. We want to engage with you. We want to know why you're here. We want you to make sure that we are all answering your questions. If we don't answer the question, maybe we can dance around it like other people do at times. We'll have our own talking points, right? So in any event, it is a pleasure to be here. Thank you again, Kate and Appian and Ferris. It's a pleasure to do this with HCEG. It has been this is our second year doing it, and it's many of our panelists. This is a second time that we've all been together. But let me just spend a moment introducing our panelists, and I will make sure then we can get started. So Lynn is our first speaker, and Lynn is the Chief Strategist for Health at the Global Public Relations Company of Edelman. She's also a board member of the Center for Healthcare Innovation, and her professional and volunteer efforts, Lynn is focused on accelerating the right care. That means making a meaningful difference in the lives of all patients, supporting the mission and dedication of healthcare providers, and transforming healthcare delivery models and supporting innovations for the future. Next is Sunnie Giles. Dr. Giles is president of Quantum Leadership Group. She's the author of The New Science of Radical Innovation that was published in 2018. She catalyzes leaders to produce radical innovation and redefine the game as individuals and organizations through organizational transformation and cultural change. She's a TEDx speaker on radical innovation. She's an advisor on the Stanford Business School Institute of Innovation in Developing Economies. I guess it didn't sound right. Okay. I think we have a misspelling. Her recent research on global leadership for innovation has been published by the Harvard Business Review. Next is Jason. And Jason Wu joined his organization in August of this year. But you must know that he's a practicing board certified OBG and a veteran with 31 years in the Commission Corps of the U.S. Public Health Service, working to advance and promote the health of the nation. Acutely aware of his own daily innovations in an inward mindset, he's joined the Arbinger Institute to help bring awareness of how we and he often get in our own way and how to get unstuck in our service to our patients, to the health, and to each other. In his career, Jason has enjoyed a breadth and depth of experience in health-related activities that are rarely encountered. His clinical leadership and executive experience includes federal, state, tribal, private, nonprofit sector, and emergency response service. I don't think you missed anything there.
Tried to cover them all.
With that, Jason received his bachelor's degree in economics and chemistry from the UNC at Chapel Hill, and studied economic development at the London School of Economics. Then, last but not least, Dr. DeLay Brandon Brandman. Dr. Brandman, she's also a physician, innovator and strategist that works across multiple healthcare sectors. For over 30 years, she's been working with startups, major Fortune 500 companies in biotech and health insurance, and provider organizations of all sizes. She's a hands-on executive with experience in startups, as I said, in information systems, data integration, healthcare data that includes the consumer, sensor, and preference data for personalized healthcare solutions. And you'll hear more about that in a few minutes. She's also worked with large companies committed to innovation, including biotech firms moving R&D to China, telecom companies expanding use of sensor data to improve healthcare. She's an expert in developing opportunities in healthcare convergence and using global issues to accelerate business value. Her specialty skills, which is dear to many of us, ACOs, product strategies, HIT, mobile health, and clinical process improvement, next generation healthcare delivery. With that, I want to welcome our panel, and we will, again, while we'll have our formal presentations and slides, we want to make sure that we are involving each of you in the discussion, so it's going to be an interactive discussion. So with that, I'm going to give the slide to you.
Power.
The power is now all in your hands.
This is pretty exciting. Thank you, Charles, for the introduction. And Ferris, thank you also for pulling this all together. I will say that if I had a nickel for every time somebody said trust in the conference, I would be able to pay for my healthcare coverage for about a month. But it has been a really interesting set of conversations from diverse viewpoints over the last number of days. And I'm hoping, and we really do mean, like, stand up, raise your hand, shout out. We'd love to have this more of a conversation than a lecture about what we can do to sort of organize this forward and do it more quickly. So you talk about trust. So in my day job, I work for Edelman, a global public relations company. And for 19 years, we've been studying trust. And I just have a few slides to let people know what the status of trust is in healthcare as just a starting point, because I heard over and over again, we need the trust of our patients. We need the trust of consumers to be able to do this. Now, what you have on the slide, and I don't know, was anybody at the opening session with the Oliver Wyman data about the problem that we don't have enough women leaders in healthcare? Well, we're going to have a much deeper, darker story to tell shortly. So around the globe, we've seen uprisings. And what we have seen is, whether it's in France or in India or in the United States, it is women who are leading the activism and the social change. And I pull out the picture of the mothers who have stormed the doors of pharmaceutical companies, accompanied by the ashes of their children who have died because they rationed their insulin. And that is a powerful force and an important reminder of what happens when our systems and bureaucracy get it wrong. Now, we take a look at healthcare from a number of perspectives, and this is our global data. And if you take a look at the global data, it looks pretty good. We break it out by hospitals and clinics, which is sort of the proxy for where you get your care. You also have biotech, which, by the way, is the innovation engine, not the sales engine. As soon as you've got a drug to sell, you are pharmaceuticals, you are not biotech. Insurance, or whoever pays for your care, consumer health and pharmaceuticals. It looks pretty good there. Things are trending up around the globe. If we just take one number, it feels pretty good. And most of these sectors, with the exception of consumer health and pharmaceuticals, are trusted. But we have a problem. In some markets, women trust healthcare less than men. And the number I will call your attention to is where the biggest gap is in the United States. because the story of trust in healthcare is very different here than it is anywhere else around the globe. And why is this important? Because we heard from Oliver Wyman what a role women play in making the decisions for care, and frankly, as employees of massive healthcare companies. So, you know, I sometimes think, well, get to know me is to love me. I work for public relations. A lot of people think of public relations just as that black hat spin doctor, as opposed to a useful medical doctor, although our clients love the spin sometimes. So I would think that there might be ways in which employees of healthcare might trust it a little bit more. And here's a problem. In healthcare, among employees, there is no trust bonus. If you were to ask energy employees, right, employees of gas and oil, employees in that sector have a much higher trust of their sector. And around the globe in healthcare, there is no increased trust among employees. So even those of us who work in and with healthcare companies don't trust our industry any more than those folks that are outside, which should be worrying. And then if we look even further, and again, I'm going to just drill down into the US story because I said I had a black cloud while I have my black hat on. Trust in hospitals and clinics in the US this year plummeted by 7 points. Compared to the tracking of our data over the last 5 years, this is unprecedented. And what you can see is that trust in every other subsector went up this year, but it fell in hospitals and clinics. Now, I drilled down into this a little bit more because I said to myself, because we all, I know I'm the perfect focus group of one, we all listen to NPR, don't we? We all do, and we all hear those stories about surprise medical billing. So I was convinced that the challenge was that people were having problems in their personal experience. It turns out that's not the case, because we asked the public, we asked the consumers that we survey, who's most to blame for the cost of healthcare. And there was no change in how we thought about hospitals and clinics this year. None at all. And I would have thought, well, what trust must be because it's costing me more in the pocket. That wasn't what it was. And then we tore the data apart further to take a look at what is a historic population that we've looked at Edelman, that top 16% of people with higher education, incomes. They tend to be, and in our definition, they're 65 and younger, so 24 to 65. I bet they're getting their insurance from a company, and I bet it's covered. And guess what? That population doesn't blame pharmaceuticals. They blame private insurers for why the cost of healthcare is high. And then this is just something because we're in an election period, in 2018, top 4 issues related to of import to the electorate who went out and voted, healthcare. 4 of them, top 4. We're really doing well on the list. It will be the case again this year, and the beliefs of people who define themselves as either Democrats versus Republicans are very, very different. And my takeaway from all of this is that we can't operate with a one-size-fits-all. Like the program that we've had here at HLTH, we've heard perspectives from a lot of different people, and what we know we have to deliver to our patients, to our consumers, to our communities are solutions to the problems because they're pissed. And another piece of data, not from our trust survey, but for those folks who are looking at what's going on inside the Beltway, Congress, not very trusted. Government, actually not trusted at all. The pharmaceutical industry is trusted less than Congress right now. You have to work really hard to go that low. So just some framing to think about. And then, you know, if I wanted to give you just a tiny bit of hope, we have to remember that in many of our communities, our hospitals and health systems, our healthcare industry are among the greatest employers. Start at home. Tell your stories at home. If your employees don't understand how that hospital bill got the way it was, or how you set your drug prices, or the solutions that you're implementing, or the new technologies that are going to change the patient experience, if they can't be your champion, you haven't done your job. The next, if you have a health tech story, tell it. This is one of the few bright spots of data. Consumers are expecting good things from health tech. Now that's broadly defined. We don't tell them whether it's a Fitbit or an EMR, but don't let that transformation happen without including your stakeholders in the discussion. The story I love to tell is I was at an appointment with a loved one about a year ago, and in a major academic medical center in a large city, one that many people know, and their EMR had just gone down, like full stop, they're entering paper and pencil. Now for us, it worked out well. We had our paperwork, we were there early, we slipped right in for our appointment. But our expectations, once we've had a taste of technology, are reasonable, not high, but that next time I'm in for an appointment, I want to know what is going to happen so that I'm prepared and understand why it's good for me as a consumer and as a patient. The other, transparency above all else. When I tried to figure out, well, what is really causing this lack of trust, we happened upon a very simple analogy. From my chair right here during this presentation, Charles, I could buy a car. I could look at reviews, I could price costs, it could be dropped off outside that hotel. I could drive to the airport back and forth a few times, right? And then if I don't like it, it can go back. I don't have to go into a dealership. I don't have to go in blind. I know what the real costs are. I can't do that in healthcare. In fact, I don't even know what my parking cost is going to be if I have to go to a center where I have to go into a paid parking garage. So make that transparency easy. Take the friction away. And then finally, activate a cross-channel plan. I may be the only person that only listens to NPR. Your consumers are getting information from many, many different places, and you need to make sure that they are able to quickly get the information they need and be able to hear it from sources that they trust, and that is a very nuanced message. Much like different groups, different bubbles of people get trust and insights from other places. So that, with the black cloud, I will now pass it off to Sunnie.
Thank you. Can you hear me? Okay, that's good. Thank you. So at some point in our lives, it behooves us to stand up and look around and see what's really happening. And that's what I would like you to do today. So let's look at the big picture. Let's think about what's happening. The environment has changed dramatically. The environment that businesses operate in has changed dramatically from the medieval, when the Industrial Revolution was introduced, from the medieval times. The environment was relatively stable in medieval times, but because of the Industrial Revolution, now it became relatively stable, so not as stable. The system is a complicated system. What that means is that you have many parts, but at the end, how the input comes out at the end is still predictable because not much changes in the process between the input and the output. So that's a complicated system. The basis competition is efficiency, because when you know what goes in, you can pretty much predict what's going to come out of it at the end. So the name of the game, how you win, and the basis of competition in that business environment is efficiency, maximizing efficiency in the process between the two, input and the output. And that is why there's so much focus on operating efficiency, maximizing initiatives such as Six Sigma, ERP, and balanced scorecard and things like that. That's what happened. That is all reflection of the environment. The next thing is that to think about then what kind of leadership lends itself to produce success in that business environment. It's command and control. Because it's about efficiency, you don't allow variances in thinking, meaning if you have different thoughts, if you have varying opinions, that has to be put away because we know what the end goal is. We just need to maximize the efficiency. So in that business environment, the type of leadership that's required to be successful is command and control. And the organizational structure that's best, that has the best chances of success in the business environment, it's one-to-many. The typical pyramid-structured org chart that we are used to seeing in many organizations even today. And because of this, a lot of the departments reflected that environment, business environment. And everything was viewed as a resource, including capital, land and equipment, raw materials, and even people. What does HR stand for? Human resources. We viewed people as part of the resource. And even legal. So think about what legal has done over the last several decades. It has been trying to systematically remove any elements of emotion in the workplace. Why? Emotions are messy, unpredictable, and represents legal liability. That, and also that is the opposite of the variance minimizing, the corporate initiatives that companies have been focused on. And that's why the business environment has become very sterile and devoid of human connection. I was surprised, and the Theresa May, it's not Boris Johnson, but the Prime Minister before Boris Johnson right now, when she first took office, she created 2 new cabinet-level positions. Number 1 was Ministry of Suicide Prevention. The other one is Ministry of Mental Health. So when you look at, because loneliness is the number 1 epidemic and in mental health, people die of loneliness because they're not feeling connected. We are built for connection. Our bodies are built for human connection. There's so many things physiologically in our brains as well as our bodies, such as mirror neurons, that are designed to facilitate human connection. But because of our pursuit of profit maximization in reflection of the environment, we had to eliminate those elements of human connection. And that's why the businesses have become the way they are. They, profit maximizing and human connection minimizing machines. But the environment is changing yet again. We're in the midst of a tidal revolution at the same level, even if not greater than that of the Industrial Revolution. We're in the midst of a digital revolution. Because we're in the middle of it, we can't feel it very much because it's such a huge trend. So the environment is now has become unpredictable. The system has become complex. What does that mean? It's a complex system. You have multiple parts in the input, but what comes out of it at the end is unpredictable. You can't control. You can't manage what's going to come out at the end because the process between the input and the outcome, there's too much variance. So in the past, leaders are charged to make good decisions, and so to make good decisions, you need 3 elements. You need information, accountability, and accountability and irresponsibility. All those things are connected at the top. They're controlled at the top. And what's happening is that the information has become decoupled with accountability at the top. So because information is freshest at the edge of the organization, where there's sales reps are meeting with the clients on the street. Cash register, cashiers are ringing up the merchandise at the cash registers. Those are, and the machine operators are operating at the machines. Those are the edge of the organization where information is the freshest. And things are changing constantly. And if you are the organizations with the traditional organizational structure where the information has to travel from the bottom all the way up to the top, decisions get made, and then they travel to the bottom of the organization. By the time the decisions reach the bottom, things have changed already. The decision has become irrelevant anymore. So that is the reality of the organization that we are witnessing right now. And because of that, the leadership style has to be what I call a quantum leadership. So what that means is maximizing self-organization, maximizing the employee's ability to make decisions, and creating an environment of safety and trust. And that's where business can thrive. And most of the time, it requires leaders to actually unlearn a lot of the things that made them successful in the past. And that becomes very, very difficult. I see this every day with my clients. The basis, because the basis of competition now has changed from efficiency maximizing to learning and innovation. You have to change as fast as the environment, or else you will become irrelevant and obsolete. And in that kind of environment, the business structure that's optimal is many-to-many, where employees spontaneously gather together free of any organizational silos, just spontaneously form a group and in response to any environmental perturbations. And as soon as the perturbations are over, and then that group just as spontaneously gets disbanded. That kind of organizational structure is optimal. Things have changed in the innovation era. Trying to predict, control, and eliminate variances are a losing game because variances is the essence of the game, not a noise to be eliminated. So a new approach that's necessary to deal with in the complex world, we have to look at how our body is built, our brain is built. At the very bottom of our brain is the reptilian brain. You know, those of you who have a medical background.
Figure model?
Yes, exactly.
There's a brainstem.
Exactly, brainstem.
There's a brainstem.
That's the brainstem. That's a reptilian brain. This is all about safety and survival. And it's very fast. It can process information in 8 milliseconds. That's 8 over 1,000 seconds. That's super, super fast, but it's not very accurate. And it's all about safety and survival. And then the next layer up is the limbic system, where his thumb is right there.
There you go.
We didn't even rehearse this, so you're awesome.
It's not a butterfly. That's your limbic system,
so
right?
that's the limbic system, and that's all about connection, and which is facilitated by emotions. Emotions are energy for motion. Emotion, they're there to facilitate action based on the input from the environment, and then that is the part of the brain that we have in common with the mammals. The reptilian brain is, as it says, what we have in common with reptiles. So it's more evolved. The limbic system is. The most and then evolved part of the brain is the cortex brain, which is what we have in common with other primates. That is the outer bark of our brain, and what's most uniquely well developed among humans is the medial prefrontal cortex, right? This is the brain model of Dr. Daniel Siegel of UCLA Medical School, and the medial prefrontal cortex is where my two fingers are, right here, right behind our eyeballs, and that is all about empathy, attunement, emotional regulation, fear modulation, and response flexibility, and things like that. So the point of all of this is that. And that medial prefrontal cortex, and that is where innovation happens. That's where learning happens. And that is the part of the brain that the companies tap into the most to catalyze innovation. But the tricky part of the whole thing is that we cannot access that part of the brain unless and until the needs of the lower 2-level brains are met first, which means you have to make sure that people feel psychologically safe first. And then, based on that, you can build deep human connection. And then, and only then, can we tap into our learning part of the brain and catalyze innovation. And that's why it's important to have this, and I'm not going to have enough time to get into all of this, but basically at the bottom 2 layers of this model that I developed, leadership model that I developed, is about safety. To provide psychological safety to your people, you need to manage yourself as a leader first. If you don't manage your anger and you just erupt constantly, you're not managing yourself, then people around you can't feel safe. So self-management is a foundational skill. Once you do that, then you can provide safety for other people. And the middle 2 layers are all about providing connection. And some of you who have studied systems theory probably understand that connection without differentiation is meaningless. Meaning, if there are two brains are always better. Is that true or not? Most time that's true. Only if then the assumption is that if 2 people have different thoughts. So and then if you are thinking the same way, it doesn't matter if you have 2 brains or 10 brains or 1,000,000 brains. If it's the same thing, it doesn't matter. That's why diversity is such an important topic. You need to have a diverse way of thinking, and then you put them together, and then the connection becomes more meaningful. And from this perspective, diversity is not a compliance issue. It has to be the strategic issue of innovation, making sure that people have, they're allowed to think differently and bring those various thoughts together, and then you put them together, and then you create a very cohesive, belonging community. And that's how we're going to meet the needs of the limbic system. And the top 2, and then the number 5 competency is facilitating learning. When you do that, and it's, learning is, it has to be spontaneous, not a, forced programmed learning. And when you learn from trial and error, from previous experiments, and you're self-organizing, those are the accidental reports that those things produce are radical innovation. And at the top it's the capstone competency, which is all about creating the ecosystem. In this digital transformation and digital revolution era, it's not enough for you to be successful on your own by yourself. You have to create an ecosystem, and you have to create an environment where everybody can thrive together. So that is these are the basic, very, very basic foundational building blocks that I wanted to share with you today.
Great.
So Jason can talk a little bit more about the safety and leadership.
Yeah, thanks, Sunnie. And I want to tie into something that you both said. And Lynn, it starts with the trust factor in our healthcare and innovation. I'm an OBGYN, so I can tell this story, right? But in the 1970s, Medicare came on board, and what became the #1 procedure done in the United States? A hysterectomy. A lobotomy, no. Well, then all the men would have been suffering from that. No, the hysterectomy, okay? Taking uteruses out. And for thousands of years, right, we didn't have that procedure around. But it became the #1 procedure. And again, it wasn't physicians. I don't think my gynecologic colleagues at the time intended to do any harm. But I'm pretty sure that the number of women that had their uteruses taken out probably didn't need that procedure. But it was the innovation, right? Yeah. And so the trust factor comes out. Were we really serving the patient, or were we doing something that we were good at, right? Something that we thought we could help. And I don't know, I can't speak to it, but it just struck me as it was literally like that, okay, where you went from other procedures to suddenly being that one. And then what Sunnie, you were talking about is how we have all become resources, right? We're human resources. We are not seen as people anymore in the healthcare system. And we talk about how are we going to get that trust back? How do we create that innovation, right? That environment that creates the psychological safety. And I think the challenge is that's where where I think at my table we talked a little bit about, and Jeff and Brian I think both brought this up. It's the culture. Oh, you're advancing. Thank you. Oh, thanks, Rick. So the topic we were starting off with was kind of how do we help better engage with innovation? How do we help bring it, right? And innovation we know is disruptive, right? And most of us say, well, that's okay, right? That's going to create change. But we have to remember what we are disrupting, right? And we are disrupting people. People who exist in relationships and in systems that they're comfortable with, okay? So when you look at, there's the same, right? Organizations and people are perfectly designed to get the results that they are getting, right? Those relationships exist, and are we just going to tell, we can all talk about healthcare is broken, but are we talking about my healthcare that's broken, my part of the system, or are we talking about other people's part that is broken, okay? So when we try to change things, okay, innovation tends to focus on changing the behaviors, right? But it doesn't address the mindset, right? The culture that we have to try and address, okay? We'll focus on changing the behavior. Just get them to order this test. Just to get them to adopt this procedure. Just change those relationships. How does that typically work out for you, right? We tend to bring in new training, new strategies, new consultants, right? But what I found, right, is most of the time we're trying to get people to behave differently without addressing the cultural aspect, right? What we call their mindset, okay? We typically see just, how many times have folks gone through a process improvement change, right? Have one consultant come in, or you start off with Lean, right? And then next thing you know, you're doing Six Sigma, and then you're doing Lean Six Sigma, right? Or in healthcare, we're doing HRO, or we're doing the triple aim, right? Or in team steps, we're doing, or the quadruple aim now, right? Because we forgot about the physicians, right? So we keep on laying these behaviors. So we do these over and over and again, okay? And we're just wasting time, and to my perspective, wasting resources, okay? So the challenge with disruption, right? When we think about that, what are we disrupting? When we get this mindset of this culture that resists innovation, right? What does that cost us, okay? So the challenge is when you have to think about people and we're disrupting people, right? People don't like that, right? It creates conflict, disengagement, challenges about why is leadership bringing this to us now, right? I am doing my job just the way I'm supposed to, and I'm doing a good job. As a physician, in my perspective, I'm the one that took the Hippocratic Oath, right? I'm the one that takes patient safety seriously. None of you other folks do that, right? I'm the one that sacrificed 10 years of my life to get boarded so I can practice, right? It's my license that's on the line. Why should I listen to anybody else coming and telling me, oh, they've got a better way to do things, right? So I'm not saying that, and I don't mean to say that that's right, okay? But as a physician, I can adopt those truths and they become my truths, right? They are my facts, but more importantly, they become my truths and the way I feel about my truths, okay? So when I have all these things, right, we talk about burnout, the lack of self-awareness, the collaboration challenges this culture creates, right? What does this do to innovation adoption, right? We want to be able to improve results, but every time we have this little aspect that comes up with the resistance, right, it begins to eat into our results, right? The cost of conflict, of disengagement, of poor leadership, of poor communications, of lack of self-awareness, of lack of poor collaboration, of I need to get better glasses, poor customer service, or I need to wear my glasses, right? Employee stress, lack of accountability. Any innovation that we try to adopt actually doesn't end up happening, right? Take EHRs. Yeah, there are other issues, right? But the promise of innovation, right, was this was going to solve all my problems, but without paying attention to the mindset and the culture, we just have a burden, okay? That's what I, as a physician, feel, right? Oh yeah, it's great to have all the data in one place, right? But it doesn't help me in my daily process. It doesn't help me in my relationship. It doesn't give me more time with my patient. It actually makes more time than I'm having to sit here and type away, right? So the challenge that we have is as long as we keep focusing on the technique or the behavior, we are not going to change the culture, right? So innovation, it doesn't matter how good your product is, doesn't matter how much it can improve the life of individuals, we're not going to reap the benefits of that, okay? Until we actually cause what's causing that, okay, when we think about that culture. So I'm going to tell a story around what this means for me, okay? How we can help. How many folks know the story of Ignaz Semmelweis? Actually, show of hands, who's heard of Ignaz Semmelweis? Okay. So another OBGYN story. It starts with the Vienna teaching hospital in the 1840s. At that hospital, it's a maternity ward. So again, I'm an OBGYN, so I can tell this story. And as a teaching hospital, it had two wards. One was a midwifery ward, and one was a physician ward. Okay, the midwives just took care of their patients, whereas the physician wards, they were trying to figure out, how do we help improve healthcare? And the mortality rates on the two wards was a little bit different, okay? The mortality rate on the midwifery ward was about 1 in 50, about 2%, which is actually below average for most of Europe at that time in the mid-1800s. It was around 3 to 4%. On the physician service, though, it was as high as 1 in 10. Okay? 10 out of 100 women would die of childbed sepsis. Some months, it was as high as 3 in 10. Okay? 30%. Okay? And it was so bad that in the streets of Vienna, and the way it would work is they would alternate admission to one service or the other. So, Monday you'd be admitted to the midwifery service. If you came out on Tuesday, it'd be the physician, and it'd go back and forth. It was so bad in the streets of Vienna that there were women that if they knew they were going to be admitted into the physician service, they would rather give birth at home or on the street. Okay? So Ignaz Semmelweis he was kind of like a chief resident at that time, a fourth-year resident. He came to do his rotation, and he started looking at the differences between the wards. Priest visits, ventilation, birthing positions, and he couldn't figure out what might be causing this really significant difference in outcomes. Until a couple things happened. The first was, as a chief resident, he was still doing rotation, so he went away for 4 months. And when he came back, he discovered that the mortality rate on the physician service had actually dropped. Right? So how do you like that? You're studying to figure out what the problem is. You go away and the problem gets better. Oh, okay. Right? But the other thing that he discovered is one day they were, as researchers, right? They were down in the morgue doing autopsies on the cadavers. One day, one of his colleagues got nicked by a scalpel. They were doing an autopsy on a woman who had passed away, and then he subsequently developed the same symptoms of childbed fever. Right? And so suddenly he put it together. Well, maybe there's something different, okay? And he went back and he discovered that while he was away, the resident that had covered for him actually hadn't been doing any autopsies, again, because it was just a short-term rotation. He hadn't gone down to the morgue at all. And so we began to think, maybe there's something about me, or maybe there's something about us that's causing the problem here, okay? So it turns out the maternity wards weren't exactly alike, right? And so Ignaz, thinking about this, thought, okay, if there's something that we're carrying, maybe there's some way we can get rid of it. And so for that, he came up with this chlorine solution that he began to wash his hands with, and required in their hospital that, well, at least on the physician service, everyone wash their hands, right? Talk about an innovation, right? Okay, that's an idea. Everybody had to wash their hands before they went back and did a delivery, okay? And so what he found was, okay, the maternity wards, the midwifery service pretty much stayed the same, okay? But what happened on the physician ward, it went from 1 in 10, right, to 1 in 100. Right, just by washing their hands. And because of him, right, in every bathroom in America, right, we have a sink, right? Every food service employee has that sign reminding them to wash their hands before they go back in to do any service, okay? So for this, Ignaz Semmelweis is known as the father of hand hygiene, okay? And do you think he kept this discovery to himself? No. He spent a couple of years, he wrote a paper, it was called The Etiology, Concept, and Prophylaxis of Childbed Fever in 1861. And the next couple of years, he went around Europe trying to help people understand this is the challenge, right? We the physicians, are doing something, and that's actually causing childbirth fever. So how well do you think that was received? Not very, okay? 2 years later, 2 of his colleagues, the story goes, had him they tricked him into voluntarily admitting himself into an insane asylum, and 2 weeks later he died, right? Because there was no way that we, the physicians, could be causing this problem, right? We're the ones that are treating. We're the ones that are trying to make things actually better, right? So the story really is recognizing that we have to address the culture, right? The mindset, right? And McKinsey came out with this finding a number of years ago, right? Organizations that address culture, right, are 4 times more likely to succeed, right, than companies that overlook that stage. So with innovation, the challenge, I think, is most of us are thinking, what's the right seed to plant, right? What's the right technology? What's the right tool that I need to do to fix this problem, right? If we plant the right seed, we'll get better outcomes. Okay? But the challenge is this. We may plant a seed. It may be the best genetically modified seed ever, and it may grow, right? It may produce something. But unless we attend to the soil, it's probably not going to grow as well. So if we think of behaviors, right, what we want to see change, we really need to focus on mindset, because that's what we need to tend to. That's where the energy needs to go, not changing the process, not changing the procedure, not changing the technology, but understanding what's the culture. With innovation, we can plant a seed, we'll get something, but how much more if we focus on the people, right? The people that are currently being treated as widgets, right, and seen as just parts of the machine. So I would go back to Ignaz Semmelweis. He's known as the father of hand hygiene, but what I think, at least for me, he really is, his greatest contribution is he's the father of self-awareness. Okay, so when we talk about trust, right, I want everybody to trust me, right? But what am I doing to trust them? Because it starts with me, right? If we think the environment is not trustworthy, what are we contributing to that? So I'm going to quickly through these. Let me pass it off to you, Lynn. I apologize. So this is where there's more material we can cover. We'll save this for the end if folks are interested in understanding how to change culture.
After,
yeah.
yes.
Okay.
Mm-hmm.
So we're going to change gears a little bit. Thank you.
Oh,
Can you hear me?
there they go.
Yes? Okay. So we're going to change gears a little bit. And as I do, I think it would be great to reflect on all the things you've heard, because I think, yes? No? They all are apparent in what I'm going to talk about. So first, before I go into my case studies, I'm going to talk just a little bit about the International Association of Innovation Professionals. That is the membership organizations that's helped sponsoring this. I was a founding board member when it got started about 10 years ago, and it's a really valuable resource to anybody that is thinking or trying to do innovation. The organization...
You're okay. Oh.
I know I need to switch this.
Sorry, the top one.
The organization started in the beginning with an international peer-reviewed journal, and the position that innovation is actually, there's actually science that tells you how to do it, how to measure it, and how to do it better. So by creating a peer-reviewed journal, we're better able to move information around the world. Shortly after that, it became clear that that wasn't really enough. There needed to be some training and some education and some idea as to whether or not the people that were trying to do innovation knew what they were doing. So the organization developed materials, training courses, a certification exam, and is still doing that today. Recently, they have started working with ISO, which is a big standards organization in most of the rest of the world, but to bring it to the US and create that sort of change. And I just wanted to make sure that people were aware of that. It's become, this is a little bit of information, and hopefully these slides will be available after, but it's become big. It's now, there are chapters in 40 or 50 countries around the world. It's particularly popular in places where they are really struggling with innovation, like China, the Middle East, sometimes places in Asia. So it is there as a resource for you, and I encourage you to take a look. So, but what I'm planning to talk about today really is what can drive viral innovation growth. We've talked a lot about some of the themes and some of the concepts, but I want to go through a case discussion of two organizations which have done an amazing job of this. The first is Project ECHO, and I'll talk a little bit about them, and then the other is Babylon Health. And in all disclosure, I'm currently helping Babylon Health here in the US, but I've worked closely with both of these organizations. So Project ECHO, what is it, where does it come from, and how has it been successful? Project ECHO was started by a gastroenterologist at the University of New Mexico, Sanjeev Arora, at the time when he was very aware of the epidemic of hepatitis C in this country. It was just at the time when there were becoming drugs that could actually treat and cure this terrible disease, but they were, one, expensive, and two, had lots and lots of side effects. So he was doing this in his clinic. New Mexico, as everybody knows, it's a rural state. And he asked, well, how long does it take people to get to see me? I mean, it's like, am I getting my patients treated? And they said, oh, it's only 18 months is the waiting list. And he went, wow, this is not possible. So how did I learn how to do this? And I know that I'm not going to suddenly be able to increase the number of gastroenterologists, but medical training teaches all kinds of people. And how did I learn? I learned by being part of a residency where I would work with experts. We'd learn some things, but then we would talk about cases and patients, and we'd learn from each other. And over a period of time, almost like, I'll call it an internship, but it's really, I mean, it's not the typical medical internship. So I should be able to replicate that. And because he had faith in people and recognized the fact that care in rural New Mexico was given not just by doctors, but by social workers and physician's assistants and in rural clinics, and sometimes they didn't get to see a doctor. And he thought, I can train all those people. So he started a Project ECHO, which was about moving information rather than people. So he would take the information that he had in his brain and in his experience and transfer it to all these people across the state. And he did it very simply. They don't really have a strong business model, but they have an amazing, effective process model. So they would have weekly conferences, 10 or 15 minutes of didactics, a few slides like what you've heard about here, and then case discussions. And he encouraged everybody to participate. If you were a rural doc or a nurse practitioner, you were required to find a patient, talk about it, you know, not every time, but and talk about it in this meeting. And other people would comment, you would ask them questions, they would have questions for you, and it became
wildly successful. It was based upon the concept that we can train people to do specialty care that's just as good if we focus on it. Everybody learns. Sanjeev learned from the people he was talking about. So it first spread across New Mexico and then spread around the world, essentially. And ECHO has gone in 10 years from a simple Zoom-enabled training conference, and it really is about training, to a global organization that is present, and I put these slides up so you could get some idea of how many of these there are. There are now thousands of them in 50 countries around the world, 200 different diseases, and it's all based upon Sanjeev's model, and he's created a network of these echoes and of these people. And they did some measuring. The first results were that the patients that got treated by these echo providers had just as good results and were actually spent less money than the things that got done at the university. And that's proved true over and over and over and over again. It was adopted by the country of Georgia, for example, and they got Sanjeev to come in and then train their doctors, because their goal is to eradicate hepatitis C in the whole country. They're well on doing that. The federal government gave Sanjeev a lot of money to implement opiate prevention, disease prevention clinics, and they've now increased access around the country. So that's Project ECHO. It's interesting to learn about, but the amazing thing is that his goal is to touch 2 billion people by 2025, and he's well on his way. No external funding and not much of a business model to do this, because having the ECHO is actually fairly inexpensive. But it's interesting to think about how he developed trust, how he changed culture, and without even really talking about that in detail. The next one I'm going to talk about is Babylon Health. Babylon Health shares a visionary CEO with the story, Ali Parsa, who is an Iranian English, not physician, just a businessman, who decided that it was not acceptable to him that there were people who dying because they had no access to health care. And he said, how do we put an accessible and affordable health service in the hands of every single person on earth? So that's his small goal, and he's off to do that. His secret was that he started with AI. AI was just coming into the forefront then, and that's a major part. He said, okay, well, there aren't enough doctors, but there's information, and if we put patients in the middle and we can share information with them, give them tools, and then bring them not to necessarily bricks and mortar, but to at least telemedicine, and then integrate with the bricks and mortar, we'll be able to get that done. So today, in 5 or 6 years, Babylon is also global. They launched in the UK very successfully. They've launched in Canada, in parts of South America, and we're now in the process of rolling it out in the US. Interestingly enough, they have a major program in Rwanda, and will be launching in a couple of other countries in Africa. They're now launching in Saudi with a partner, as well as Australia. So again, rapid growth, becoming global, trying to get every person access to healthcare. So those are the case studies. I think people will probably have comments. I'd be interested in people's comments or questions from the audience. I think we're ready to go that direction now.
Yes, thank you very much. We've enjoyed even a live demonstration. Are you able to hear me okay?
Yeah, we've got mics.
Okay, great. So there's a couple things that this is our opportunity to have a discussion and to ask those questions that you mentioned earlier. There's a lot that we've discussed. We've even had some live demonstration of what it means to work together towards a solution. So thank you, Sunnie, and thank you, Jason. But we've heard a lot about innovation. We've talked, as I started looking at a couple of things that that kept coming up here, is we've talked about trust and improving trust. And I think that's something that we need to focus a little further on. When I saw Sunnie's slides on the quantum leadership, sometimes I think that we're no longer holding on, that we've actually fallen from that cliff. So hopefully there's a way to get back up. The other thing I heard was connectivity. And I keep going back to so much of what was said here. You know, my buzzwords are interoperability, connectivity, the patient being able to have the information at their fingertips and to be able to use it. So, of course, we've talked about some of the challenges, and I'm interested in us looking further into what Lynn would say would be the outcome of improving some of the trust factors and looking at some of the disruption and what we can do with our culture. More time with your patients, and I'm thinking that, yes, the EHRs are a blessing and are also cumbersome. But maybe if the information is all together, we've broken down some of the barriers to exchanging information, maybe then we can actually use the EHR for the good reasons that it was made for. So the last thing we need is for the EHR to be a burden to the providers and therefore to get in the way of innovation and to get in the way of patient care. We also talked about not only the growth of ECHO, but the growth of innovation and how we can do it one step at a time. Again, we go back to innovation. So there's a number of things that we've talked about. Many times it goes back to how do we connect each other and how can we improve our trust factor of each other so that we don't have people thinking that they're pushing us off the cliff, that we actually are working together to improve the system towards who really matters here is the patient. So what are the issues? But what I'd like to ask from the audience is, let's have your question that was asked a few minutes ago, and hopefully it will be followed by some other questions. And we have mics that are in the audience here? Great.
Hi there. I'm Alexa Cushman. I am with Appian. So I had a question specifically for you within OBGYN and within changing the culture and within innovation. Earlier, it was touched on, human resources and humans as a resource. So as a woman of childbearing age within the United States, I feel often like we are seen as a resource for reproduction. Mm-hmm. There is, there's been many strides within women's rights, obviously, but we are still culturally often seen as that. And it can be a cultural taboo if you are physically unable to have children, if you choose to not have children. But one of the things that we've obviously seen, and you probably study often, is the rise in maternal death rates within the United States. How do you see a change in culture and using innovation to help curb that, and also ensuring trust within your patients? I delivered all 4 of my children in the DC area where you practice, including a set of multiples. So I know what it's like to come in and be told, you're paranoid or don't worry about it and things like that, when really they may see 8 patients a day, but for you, it is personal and you do care about it and you don't want to be treated that way, especially as a woman. So how does innovation change that culture?
Yeah, that's, is Alexis?
Alexa,
yeah,
yes.
Alexa, thanks.
Like Amazon.
Sorry, Alexa, thanks. I think part of the challenge comes is that we are all smart, dedicated people, but we're focused on the wrong thing. We're focused on fixing the system. We're focused on coming up with what's the right way to put all the pieces together, what's the grand strategy, and we're forgetting the people, right? So I don't see my job as to fix the healthcare system. I see my job as to fix my relationships one at a time, right? The challenge is how do we help invest all of us with that way of seeing, right? And recognizing, look, it's great to have these plans. We need to be thinking about, we need to work together to figure that out, right? But me complaining that, oh, the other side doesn't get it, or those providers, oh, it works at my hospital, but not here, that's not helping, right? All we can do is, what's my circle of control? And my circle of control is the people that I am in relation to, right? And when I'm in relation to them, magic happens, right? Because then trust comes, right? Trust is not this great nebulous thing that just tosses out there. It's not a word, right? It's between two people, or at least two people. It has to be between. It has to be in connection or in relation. So I think the first thing is to figure out, how do I be better in the relations around me, right? If I'm a patient going to the hospital, right, I have to think about I have to see the providers that are there, right? Recognize my nurse may be overtired, right? My physician, I may be the 5th patient that he's seen, or 50th patient he's seen, right? But then, okay, I am there for a need, but I also have to be mindful I'm in relation to someone. And so if I just go in with my needs, right, then I'm treating them as objects, right? So I have to be mindful of what I'm projecting. We're not going to change the culture with one magic swoop, right? It's about changing one relationship at a time. Does that make sense?
I want to add to that. So with my Center for Healthcare Innovation hat on, we've, as an organization, have really begun to focus on equity and inclusion in healthcare. And one of the things that I'm fascinated by with the model of the brain is it's really hard. I heard one great thing today, that 25% of your calories are burned through the electrical impulses of your brain. And that's a good excuse not to go to the gym for me. I'll just sort of think a little bit more.
I like that.
I do. I like that a lot. But
got to think harder.
I think I will. But it's also hard for us to accept things that we don't understand or agree with. So we sit inside our own bubbles, right? So you probably look at one news channel that maybe has one set of presenters or a format of a program that you are comfortable with, and looking at a different channel may be a little bit of a problem. And this ability to just surround ourselves with self-reinforcing information is one of our greatest risks, because we don't have the sensitivity and understanding of that other person or community. You come to the situation, you come to that relationship with a bunch of assumptions that are usually probably not right, right? So and you see it in the authority between a doctor and a patient. You see it in the way that people sort of mechanize their engagements. And then if you can actually start where that person on the other side of the relationship is, you're going to get to a successful outcome much more quickly. Yeah. So it's really that exercise of being able to do that.
I like your point is that, and actually your assumptions, they are right. They're right for you, but they are assumptions, right? So I can be right. I can view the world in a particular way. I can be absolutely right. Remember back to my facts, right? But I might be wrong about the circumstance or the situation, right? So I'm actually hiding the truth from myself. When I don't understand why I'm finding resistance, why you don't get it, right? If I don't get curious about what it is why you see that way, then I'm just creating my own resistance, right? I'm creating my own stress. And that's the critical thing about seeing, right? It's, if we see others and recognize they have needs, objectives, and we recognize we're all coming to the table we all woke up wanting to be happy and wanting to be valued, right? We all did that, right? Why is it that Charles is sitting there and he's disagreeing with me, right? If I feel resistance and I want to get defensive, and in fact, I'm creating all that resistance. But if I get really curious about him, right, then that opens up the opportunity for understanding. You know, and VUCA, right? And I was hoping you'd pick on that again, because it's a term that the military has been using, you know, to describe the world global security. And VUCA, it's volatile, uncertain, complex, and ambiguous. Right? And the way we change that, right, is starting by how we see each other. Because to me, vision, right, to see others creates curiosity. When you get curious about others, you get understanding, right? When you get understanding, then you understand where they're coming from. That's what creates the clarity, right? The opportunity for collaboration, and then we become agile. So I love
Ladies
VUCA.
and gentlemen, this right here is a 90% of the organizational interpersonal conflict source. This is right here, right here. People are talking about things as though, from their own point of view, their own mind frame, which is based on their past exposure to from their life experiences, and they don't get that the other person has a whole set of different understanding and way of looking at the world. And they go, well, and they keep arguing about the smell, the taste, the shape of this, orange and the other person thinks that's a pear, and then in reality it's really an apple. So that happens like so much, and that is the root cause of so much organizational conflict.
Yeah, and I like the neurobiological model to me, the neuroscience model, is it gets back to that reptilian brainstem, because again, maybe this is too much science, but that's sympathetic, parasympathetic, it's epinephrine, norepinephrine. Yep. When we get to our emotions actually, they have maybe a Darwinian evolutionary function, right? They make us efficient, right? When I feel threatened by something, that tells me to run faster, right? When I feel bigger than something, it tells me I can beat it up. I don't have to run, right? That emotion that will help drive that. The problem is in today's complex world, right? When we're responding to our emotions, we're not aware of what the facts are, right? The fact that other people are sitting in their room and have their own approach to it, and we're not open to that. Yeah.
So I think that's a great example of why Sanjeev was successful in terms of what he did. So he had that same experience. He was a professional academic physician, and that's where people come to get treated. And I had a conversation with a group of academics at a Boston hospital who are very much the same. And we were talking about, well, how do you get to the community? And they were going like, well, we can't do that. We could never give them good enough care. They have to come here. That's a given. Yeah. And Sanjeev said, I can't get them here. It's too many miles, and I think it's okay. So I will trust those doctors, and I will have them trust me, and we'll educate, and we'll become peers. And we'll actually then spread my abilities throughout the state. And because it was so exciting to those physicians and that became such a coherent group, it echoed, it replicated everywhere across the country. And now there's at least 5 or 6 different echoes in every state in the country.
Yeah. We have a question over here.
Well, this was a handoff. So I had a couple questions just as it relates to patient empowerment. We had a very rich discussion at our table prior to the panelists coming up to the stage. And I wanted to just hear from your perspectives, what are we doing? What are some of the more impressive means in each of your experiences for patient empowerment and tools, innovation, just your thoughts around that. I'd love to hear.
Anyone want to start?
No. I'll go to the end. I will defer to, I think we should start with
the doctors.
With the doctor.
Yeah. Here you go.
Because as patients, we're going to take your authority away, but on the stage,
Right,
we
we're
can give
gonna-
you a lot of
That's
feedback.
We're trying to give it away. So you don't have to worry about that. And that's one of the things that the AI can do. So if you look at the situation in Rwanda, no doctors, hardly any. Lots of patients needing information, taking matters into their own hands, doing things in the way that they've done it traditionally over a period of time. But by giving them information and then allowing them to have access of exchanging information, they have become wildly more empowered. They're solving things like maternal health, treatment of malaria in ways that they could never do before, but it is because they are at the table, and the respect that the Babylon mission, and it truly is a mission, says you're first, you're in the middle. We will be transparent with you. This is what we know. This is what we can tell you. What you tell us, we'll listen to and respond, and together we'll do it as a team. But it really is as a team. And when you have a place where there aren't doctors, it's immediately apparent. It's a little less apparent here in the US about how well that's going to work, but it's the same theory. Patient in the middle, starts with them, listen to them, and then share everything that you say. They should know everything about what you're doing. They need to basically be driving some of their own decisions about when they get treatment and when they don't. And that's just it's a vision.
So it's the empowerment of information for the patient, and then for the trust both ways between the patient and the other person at the end, whether it's a physician, PA,
Right.
whatever it might
And I
be.
think it has to go together. You can't just hand them information because, one, they will not necessarily really understand it. They may have a bad, so we have the anti-vaxxers, people that are refusing to vaccinate their children. They have information, but they have no trust. They don't have any trust with the science community, with their doctors, and they are isolating themselves. And so you have to bring both. I trust you as a patient to think about what I'm telling you, and you trust me to listen, that I'll listen, and we'll have that that dialogue as equals.
Yeah, I think information is very powerful, right? And that's where the whole movement of helping patients gather their own information is important. But information without, being categorized, right, is just information, right? It doesn't become knowledge until there's some trusted relationship or to that information. And ultimately that trust has to come from somebody learning how does this information apply. Now where they're going to get, is it going to be the physician? I don't know, right? Is it going to be Fox News or some other news channel or whatever? I don't know, right? All I can speak to is my experience is that if when the internet first came up, right, and patients were coming in with all their alternative medicine theories and websites, I know when I didn't respect the work that they had done, and I just poo-pooed it, I got a lot more resistance than, well, tell me, where did you get that from? What do you think about it? Why do you think that matters to you? Or why does that matter to you? What are you concerned about? And then when I get to the concerns, and then ask them, okay, that might be one sort of, this is what I know, but I build the relationship with the first. That was a completely different response to that information, right? So absolutely getting information is important, but until we figure out who is that trusted intermediary and how are we going to help facilitate the patient's trust in that, right? And their connection to someone else, right? We're not going to fix that, right? So we can dump all the information on them, but it will get picked up by the North Korean trolls or the Russian trolls, whoever's trolling that and turned into something else, I think. I don't know, but I think information by itself absolutely can be very powerful, but powerful for bad too, as well as good. Yeah. Is that interesting? It's Rachel, was it?
Yes.
Yeah.
So, I just want to be a little controversial. Are there any EMR systems that are fully transparent to their patients?
I'm not the tech. You probably know more tech. Are there any EMRs that are fully transparent? What do you mean by fully transparent?
Fully transparent, meaning there are no provider notes that are not, everything's exposed. Patients have full access to whatever notes are in their record.
I'm not aware of
So that's
Somebody has an answer.
We have an answer over here, but I think we all have opinions here.
Yeah.
I certainly do.
Somebody get him a mic. Is there an extra mic?
It was someone else here.
Okay.
Sure.
In the Northwest, you have a lot of, Portland, et cetera, you have a lot of adoption of the open notes concept, which I think is really the more important thing. It's not the technology. The technology is not the barrier. It's the acceptance on the part of the clinicians that they can trust the patients to expose this. So, if you look at the open notes concept, it's really not a technology barrier. In my opinion, I'm happy to
I think,
hear.
and I believe that we probably would all agree it's not a technology issue. I think what we have here, though, is personal experience, which is I have access to, and it all depends on my specialist and which hospitals I've been to. So I think I have 5 or 6 specialists in hospitals, and guess how many EMR systems do I have? 5 or 6. And I want the access to the clinical notes. I want access to the procedure that the notes from the operation that I had, so I can share it with my other physicians. And I think that that's what we're asking here is, when is it, are we going to trust the patient with that information? The technology, I think, is there. It's really, I have to say, if you look at some of the systems, they're very rich and usable. And what we need to do is make sure that, in my case, with all of the different EHR systems, that we can communicate. and we're able to connect those so that we all have one information, and I have that information that I know and I can share with my with other doctors, so they all can be involved in my care.
Yeah.
Right, and I think this is a great example of Jason's point about culture. So 20 years ago, in San Francisco, there's a hospital called California Pacific Medical Center. It's very well known, it's very sophisticated, and San Francisco being a liberal city, they decided that, well, we're going to have one ward in our hospital, and God forbid, amazingly enough, the patients will be able to go to the nurses' stations and, one, read everything that they're, and they will be able to put in their own notes. They'll be able to ask questions, they'll be able to comment, they'll be able to contradict, and they'll be able to bring their own food and prepare it if they decided that they wanted to do that. So, and most of the doctors refused. There were a few doctors that went and said, okay, sounds good to me. And what they found is that that one ward was so oversubscribed. So every single patient that wanted to come in that had an elective case or was getting hospitalized, they wanted to go on the open ward. And then other doctors got recruited, and it became very popular. It wasn't ever really written about. I don't think it really went anywhere, but it was just a matter of a hospital administrator and a couple of physicians making a decision that this was the right thing, and it was going to be good for everybody. And it was massively, people got better, they went home sooner, they got less complications.
Yeah, I wouldn't blame the EHR. I can't believe in this day and age that this is a technical problem. It is not, right? I mean, shoot, my phone is in the right, the challenge would be like, right, in communicating with your doctor, and I'll just, for my example, right, if a patient wanted to text me, right, how free do I feel to text them back, right? Because how do I know it's actually going to the patient? Now, and so this is where we can use HIPAA, right, as an excuse. And it's not just the physician, it's the hospitals too, right? Because there's a liability concern. I don't know if it's a true liability. I do know that and maybe this is better, I haven't been paying as much attention to what tort cases, lawsuits were in, but I had a colleague who was sued because his patient had a complication post-surgery because and again, he didn't do the surgery, but he called the patient's home the night after the surgery to check that she was okay. She didn't answer, her husband answered, right? And he said, oh, she's doing fine, he did the call. Well, he lost a suit because basically she ended up getting sepsis and being back in, and he was found liable for not actually having spoken to her directly. Now, again, that's just part of the environment around us. So I don't think it's technological. It's a matter of culture and choice, and it's based on that relationship, right? There are some patients that I know, if their only way they want to communicate is through text, I'll text them. If it's only on the phone, I'll do that, right? But that's based on a trusted relationship with them. It's not something I think we're going to solve systematically. And I think the capability's got to be there. I can't believe that the interoperability really isn't there.
We have another question over here.
Yes. Yep. So stepping away from the industry for a minute, Sunnie, I loved your comparison of kind of the medieval to the industrial to the digital leadership era and how we impact change. Coming from Marine Corps infantry leadership, where we were medieval bordering on industrial, to now working in a health plan where we're very diverse, inclusive, many-to-many model, as you would describe it. I've seen how technology and culture can impact change, and change is great in that many-to-many model. Where I've seen struggles, though, with the cultural change is what I call the diffused accountability model. So you talked about the keys of innovation being information, accountability, responsibility, I think.
Authority and responsibility.
Okay, so how do you give me some examples or techniques that you've seen in changing the culture in the many-to-many model along the lines of authority and responsibility? Because I see us falling short there, partly as an industry, as we collaborate amongst each other and we talk about innovation and collaboration together, but who's authoritative, who's responsible for each of the variable components? Just interested in your perspective there.
Yeah, this is a very tough issue because to grant and allow, bestow accountability, authority, responsibility, and information, 3 components to make good decisions to lower levels of the organization. It goes back to the issue of self-management as a leader, because most of the time, they end up feeling threatened by empowered employees because they think they're going to challenge their authority, or they're going to somehow undermine their agenda. And that again, it goes back to the trust factor. When they know that okay, so I'm going to say a 4-letter word for at work. It's love. Okay? So it's not enough that you care about your employees. You have to actually love them to a point where you would go without your mortgage so that they can make their payments. A lot of the times they go, no, I'm not willing to do that. Or when I say, you need to be a point where you are willing to sacrifice your career trajectory to take care of your people. Oh, no, I'm not willing to do that. Without that level of putting the other person first, it's hard to establish the trust. When you have the trust and that instill the trust in people, then it's not about you. It's about the other person, caring for and loving the other person. And then they know that you will go to bat for them and stick your neck out for them and take all kinds of risks for them. They will do anything for you. They'll go through the fire desert for you. They'll take an underwater basket weaving class, whatever it is. They'll do anything for you. So it's a mutual relationship of trust. When you establish that, then you are willing to then push down on your fear that says, what if he undermines what I'm trying to do? Or what if she gets ahead of me? That is all based on your fear from the industrial era. Things are changing so fast. There's no such thing as the all-knowing, leader that knows how the game's going to get played out to the end. You don't know that. That's why you have to be humble enough to accept the fact that you don't know everything, and people under you actually might know better than you. And then that allows you to just put your fear at ease and say, okay, I trust you to make the best decision possible because we are in this together, and I look out for your best interest. And that's how you can give them the authority, responsibility, and information, especially information, because information is power. Don't try to hold on to them. Share everything that you know, unless it's illegal. Share everything with them so that they can make the best decision possible and best informed decision possible.
Sunnie and I use different language around this, but I think it gets back to, for me, it's about seeing somebody as a person, right? Sunnie described it as everybody wants to be loved, everybody wants to be trusted, everybody wants to have authority and be able to grow, right? But the job as a leader is not to hold people accountable, it's to create accountable people. Right? It's like I have a 5-year-old. My job is not to make him brush his teeth, go to bed. It's to develop somebody who wants to brush his teeth and go to bed on time, right? And I think the same thing is within an organization. It's not what we do to people, right? That's going to make it's not. I would say it's not making their mortgage payments. It's not doing that. It's about seeing them as a person, right? And not just giving them responsibility and authority, right? It's developing them. So, to say, hey, you're in charge of this mission, right? It's go plan and do it. That's not seeing somebody as a person, right? That's not giving authority. That's just putting you in a position where I can blame you for when it doesn't work, okay? Or take credit for, I put a great person in charge. It's about seeing somebody, right, and saying, okay, what is it that you need now? What are your challenges? What is it that you're trying to do? How do I help you grow? And I think it's just, to me, it's a different language. It's about seeing folks and not what we do for them. Right?
And I would just add, so, what do public relations, and, we are brought in and are partnered with companies that are looking to solve problems or shape worlds. And for us, the things that I've always found to be most important is the process. The process, the organization, bringing the groups together, having agreement about what we want to look like down the road, and then having everyone engaged in getting there. So it is as important as ensuring that people have responsibility as that they are also engaged along the way. So to get to that point where we have really great patient engagement, we're able to trust them, it also is incumbent upon the organization to evolve and engage its stakeholders in a way that they are part of that process to get there. It's not just something that's done from on high, right, as Sunnie laid out so beautifully. And as anybody who's got a teenager knows, how they learn and think and communicate is radically, radically different. The idea of a phone call does not exist There is like this sort of ambient background digital connectivity where they are with their peers, like not in the way that we think about making a phone call, but in which they're exchanging information and developing solutions and frankly, working as teams. That is a whole new model. Yeah. I do wonder, and no disrespect for people who are currently doctors, whether it's like, well, let's just start with all the ones that are graduating now and see if they can help bring in a wave of change, because their behaviors aren't baked in, and their cost of adopting new behaviors is not as high.
Yeah. We have a question over here.
Yes, I'm just interrupting, sorry. We're about to pick up the food, so if you guys want to grab any food before it gets picked up, please go ahead and do so, and then we have another question over here.
Okay, so make sure you enjoy the desserts and coffee before it's
Link, can I
taken
just
away.
add to your point? I think it's more than just the teenagers. So it gets back to your point about diversity, equity, and inclusion. All of us think and see differently, right? And it's when we see that, we see that everyone, no matter their skin, their race, their sex, or whatever their experience history, brings something else to the table. And that's when you're including everyone. Not be the leader that creates the vision, says this is where we're going. It's where are we going, right? Where are we going?
Good point. We have a question right here.
Fantastic presentations. Thank you all. Mine isn't really a question as much of a clarification from Jason. I loved your analogy about the soil and the planting of the soil. So what you're talking about, what you've been talking about just now, the sort of compassionate leadership, one-on-one communication, is that how you cultivate the soil?
Yeah, no, so this is really great. Thank you for this clarifying, because it's not about the behaviors we adopt. It is simply being alive to other people. It's how am I seeing, right? Because if I'm worried about being seen as the compassionate leader, being the inclusive leader, I'm taking on a title that now is defined by me and how am I being perceived. I'm no longer alive to Brian. So the only way I can actually be any of those things is to not be worried about being them, but being curious about Brian, right? And that's what I mean by seeing. And so the term I use is mindset, and there's a lot of different, in fact, when we start with Simon Sinek, start with why, get to the vision, he's now on the infinite mindset, finite mindset. Mindset is not a belief system. It's not a belief about who I am. I mean, these are important. It's not to say that, but ultimately when we are engaging with others, what is me is not as important as what is about you that I don't understand and that I need to know. And that's the way that's the way I need to enter the room, right? Being concerned about what's Lynn's thinking about today? What is it that she wants to accomplish, right? What is it that you guys want to, if I'm alive to that, then it doesn't matter what label I'm giving to myself. Right?
To do that,
yeah, okay.
To do that, I think we need to actually reintroduce emotions in the workplace. Emotion is what connection is made up of. Without emotion, you can't feel connected. Go ask your wife or your husband at home. Without emotion, you can't feel connected. But we've been systematically trying to eliminate emotions in the workplace. And that's why we are so lonely and so cut off from everybody. And we are the loneliest generation in the history of human history. So we need to reintroduce the elements of emotion in the workplace. That means we have to. Again, it goes back to trust.
Yeah.
I'll just add on that. One of the things that we saw in our trust barometer this year is that when a CEO posts something publicly, takes a stand publicly, is willing to declare something publicly, the benefit to employees is profound because they see their leader representing their organization. And your relationship with your employer is one of the strongest trust bonds you have. So when we help our clients understand how to have better engagement with their employees, when we say to them, in fact, the first step is to be public about it, all of a sudden everyone is just like, look, he's embodying what we are part of as an organization. And that gives us pride and builds our confidence.
Can we have another question right here?
Yes, that's a great conversation about the interpersonal dimensions. And that's fantastic, but often, and I think the gentleman over there was getting to, as was the EHR question, the issue of the governance of risk. And that is, especially in a regulated industry, is really a challenge. So the governance of risk, the governance of new technology, the governance of innovation, and how that is done in a new and agile space. That's one of the challenges that a lot of our clients are facing. And I guess my question or observation, a mix of both, is we know that Facebook's move fast and break things model of technology governance is a no-go, and it might not even be not just a no-go for healthcare, but for other realms going forward. But the old command and control, where the regulations were slower, I mean, what FDA is doing with their pre-cert program, et cetera, there's new models for governance. And I'm just wondering if people here have thought about how those new models of governance have to be intertwined with not just the regulatory governance, but the governance of risk and resources within an organization, and how that dovetails with this new employee empowerment many-to-many.
I'll take the first step at it, if I may. Is that that's a really important question, because the learning that needs to come from self-organized people taking their self-initiative and then learning from previous experiments of trial and error, that is how innovation. The accidental result of that learning is innovation. So then, if innovation is the only way to survive, then how are we going to, allow that to happen without actually breaking down the organization and killing the organization in the process? One of the best practices that I've seen in the industry is divorcing the accountability from the learning. So let me give you an example. I have a client who has a pot of money that is separate from the regular P&L. So that's a pot of money that you pitch to that innovation committee, your idea, and then if it passes, then they actually get some budget allocated from that pot of money. And that, whether you succeed or fail, doesn't get incorporated in the current P&L, which empowers them to take risks without the pressure of delivering results in the current period. That is just one of the best practices that I've seen. So it is critical to separate learning from accountability.
Can you clarify your question for me? Sunnie answered it around, I think, the organizational internal, but are you talking more about the overall an organizational governance or the broader governance of healthcare and regulation?
Primarily internal within the organization. Of course, it has to take into consideration that there's regulations and there's laws, but within the organization, that's what a lot of the challenges that...
Right, and the challenges get back to, are we trying to enforce compliance and behavior, or are we trying to create people who are accountable for their own behavior? Are we trying to create a culture where we are having clear roles? Right? So, being able to create that culture where folks are engaged, we're spontaneously solving their solutions, right? Working together to do that, doesn't come from regulatory oversight and saying, you have to do this behavior. It comes from saying, look, here are the behaviors. We're all stuck with these, right? How do you do this and still provide the best patient care? Come up with that, right? Tell me, what is it that gets in your way, right? When you're implementing these requirements or these procedures, right? What's getting in your way from good patient care? And then let's figure out who do you need to work with in order to provide better care in that environment. It doesn't mean we can let go. I mean, again, safety regulations exist, maybe not necessarily for a good reason, but regulations are an imposition of compliance, right? They are not creating the culture. They are what we have to, that's the reality. We have to deal with them, right? Wash your hands, have a checklist. But these things can be, they can be used, again, it's a tool. It can be used from an inward mindset where we're enforcing compliance, or it can be from outward mindset. It's like, look, these were created to help deliver better patient care. From your perspective, and in whatever that staff is, how does that help do that? And if it doesn't, help us figure out how to solve that. Does that make sense? No.
I actually think one of the most, I don't know how you solve it. I think that's one of the most complex situations, and it's the nibble effect on the effectiveness of innovation. I mean, just in terms of what you said about the doctor who got sued because the doctor did a valuable thing, checking on the patient post-op, having a discussion with the husband, the loved one, a shared caregiver, conceptually great.
Yeah.
but they got sued because the regulation said, no, you have to basically do this. And so I think where innovation struggles is at that intersection between the regulation and the people-to-people decision about how they're working and making things work, and it getting slowed down.
Right, and I agree.
It's a risk.
It is a risk.
Get rid of the regulations, but maybe it's just a painful process.
I don't think you can get rid of the regulations. I think there is always risk, right? There is nothing that's 100% safe. Right? I can do everything by the book and still get sued, right? I can do the best patient care and still get sued, right? But if I'm worried about that, then I'm worried about me, right? I'm not worried about the patient, right? So what we have to do is create that culture where we are not patient-centric, but whoever the patient, if Charles is the patient, we are Charles-focused, right? If Lynn is the patient, we are Lynn-focused, and recognizing that there may be a different accommodation that we have to take for Charles as a service provider than we might have for Lynn, right? But we don't create that culture of adaptability, of agility, by holding people to compliance, by trying to hold them accountable, as opposed to helping create a culture that wants them to be accountable to the patient, right? To Lynn, to Charles.
So we have another question right here.
Thanks for the enlightening discussion. So I often think about this, innovation when we say, per se, is fundamentally about advances in science and technology. And culture generally follows advances in technology. I mean, it's been out there for ages now. You know, you talk about the Industrial Revolution, but the culture that evolved around it was, you know, following the technology advancements that happened in that age. And it's the same today, you know. Texting as a mode of communication is much more accepted and it's commonplace, whereas it was not 30 years ago. That was weird. And as an organization leader, what I struggle with often is the fear of losing out, because there are organizations out there who are leading this, right? Players like Amazon, who fundamentally advance on things that are at the cutting edge. And when you look at it, you sort of start seeing the inevitable. And I just wanted to see how you guys think about that.
So I think the question, and help us understand, is when you're seeing all the other stuff that's happening, right? Culture, what I heard you say is culture is changed. There's acceptable technology, and some of these, maybe these big disruptors, right, are going to drive the culture, and we're just stuck along for the ride, and we have to do what ends up happening with that. Is that what your question?
Yeah, exactly. And if I don't end up doing that, maybe I end up losing.
Yeah. So I guess it gets back, for me, it gets back to what's my circle of control, right? And to say that culture is what is out there, there are lots of different cultures, right? The only culture that really matters is the one that I'm engaged with, and that is the folks that are around me, right? If I'm worried about what the culture is in China or in Russia or in India or anywhere else in the United States, that's great. I can be the smartest person in the room and know all about that, but does it really impact me, right? So who's the culture that I have to engage with? Who are my partners? Right? Who are the people that I'm working with? So if it's in the hospital, if it's in the regulatory environment, it's the research environment, who are the people that I can affect? Only the people that I'm in relation to. Right? So we create the culture that we want. Right? There may be other things that are happening, but that's going to happen irrespective of one. An asteroid may hit the Earth, boom, right? Maybe that's a little extreme, right? But it gets back to things are outside of our control. Why are we bothering? Why are we worried about it? We can complain about it, we can blame it, right? But that doesn't change what we have to do on a day-to-day basis. And if I'm not accountable for what I want to create around me, then why am I complaining?
Most of the problems that we have talked about today, as well as most of the problems that are that we witness these days, are intractable because they're systemic in nature, meaning they are because of the nature of interdependence. What I do has an impact on you, in turn has an impact on me, which in turn impacts you. And because of that, it's really hard to come up with a solution that can solve all problems, all aspects of the problem in the system at the same time.
And it can. We've been building this system for over 100 years. Right?
So the best way to address systemic problems that are intractable in nature is to start with, just like Jason said, start with your scope of control. So let me give an example. I had a meeting with this client. He is the head of European operations, like big hunter of all the EMEA, Europe, Middle East, and Africa, of one of the largest electronic companies in the world. So I went to his office in London, spoke with them, and presented my thoughts on innovation, how to approach it, and what kind of programs they can introduce to change their organizational culture for innovation. And he looks at me and he goes, I am just a cog in a wheel. I'm thinking, wait, if you, the head of European operations for this company, is a cog in a wheel, how is your company ever going to change? And he says, well, what you need to do actually, introduce this that touches on the HR policies that are global in nature. And if I make some changes here, then what's going to happen to my counterparts in Americas and then Asia Pacific? And so I can't do that.
And one of the things that excited me about this conference, I don't know how many folks, but it was just the whole variety of folks. Some of this is policy, right? But you can affect it in so many different areas. You have these startups that start up in their little community and suddenly they're global operations. You have little lobbyists, a mom who has a 5-year-old now who just wants to start seeing, making an impact on lobbyists. She's just started taking her kid around Congress and showing them this is the impact. And now she's got this national organization that is, we can all affect that structure. It's just choosing, is that what we want to do, right? So we can blame the system. We can blame 100 years. We can blame, Osler and all the other founders but it doesn't change anything, right? We have the ability, and that's, I think, what to me is really exciting about this conference is all the different ways, the breadth and depth of folks that can do it. And who was the guy yesterday who went he used to run Landmark, he went to Adam, whatever. But this is a guy that strikes me, he started something, right, and now has a different role and it's in a role that he just didn't see himself in because it was important, because he looked at the scope, the networking that he could do, and who are the people that he could influence, the ones he's in relation to. And so he's in a role that he would have never considered for himself. But I think we all have that capability. It's just deciding who we want to be in relation to.
So the suggestion is start something, track the results, and do internal communication, like up the wazoo.
Thank you.
So do we have any other, this table, okay, yes, we have a couple here. We want to make sure each table discussion is recognized.
Your last point there, Sunnie, you brought up tracking results. A lot of what you talked about, the output is hard to measure now, and innovation isn't really something you can put just one metric to. So can you speak to, and everybody feel free to chime in, how do you measure success, and how do you communicate that to then spread innovation within the organization?
That's a $24,000 question, right? That's it's a hard one. So the typical thing that I see in the industry is the number of patents per employee, or the percent of revenues coming from new products introduced in the last 3 years, that kind of a thing. Those are the things that I see very commonly in the industry. Because innovation in and of itself has so many different components that affect the outcome, you can't just track it directly. And so I always recommend my clients to track the intermediate variables that lead to innovation, such as those 6 competency groups, and then providing leaders that are, what is their level of self-management, providing safety, creating differentiation among people, creating connection, creating learning, facilitating learning, and then creating ecosystem and all the components that are involved in it. Those are very tangible behaviors. So you can track those. And then at the end, and then innovation, there's a component of serendipity that's involved. So that's the part, that plus alpha, that's hard to measure. So you need to combine several things to measure.
And I will chime in. One of the things that we modeled with the University of Chicago's business school, the Booth School of Business, was a test as to whether or not trust had an impact on stock performance. And it did, and it does, not only in the performance of your stock, but also recovery after a crisis. And so the sort of collective ability to meet the expectations of your stakeholders, and thank you, communicated internally up the wazoo, that's a good technical term.
I don't know what a wazoo looks like, so I can't do that.
Describe it. because you're not a gastroenterologist. But the goal is that people who are taking risk, right, and who are making change, and you're public about it, you can earn trust if you're staying on your mission and you're focused on your end goals, and your stakeholders know the journey that you're going on. And so I do think, because the thing that I am fundamentally impatient in before this panel, in the event that our audience wasn't going to ask us questions, we gave a few to Charles, and I'm just sort of like, how do we move this faster?
Yeah.
And I thought that Adam's comments yesterday about the fact that fee-for-service will be gone in 5 years, well, that's pretty sexy. That's pretty exciting. And then along the way, some of the things that I thought were also incredibly helpful from this conference are people who were telling stories, right? Because we respond to storytelling in a way that's different and it's fulfilling. The people who were telling the stories, there was the head of Alina Health who was talking about a mother who had cystic fibrosis, and that the fundamental difference in her health and the prosperity of her family was getting her washing machine fixed so that she didn't have to go to the laundromat. And all of a sudden, that makes the prospect of this very real and very vivid in terms of how we think about transforming healthcare and getting our heads wrapped around it. Because in fact, this whole system thing is so big, it would seem intractable, but then you can begin to see how one step can beget a positive outcome that then becomes a collective movement and a behavior across an organization.
And you have to get to that impact, right? Because I think, John, the question you ask is more around how do you measure it internally, right? In patents, I think it's a great one, right? But that's not an impact metric. That's a process or an output metric, right? Maybe even an outcome. But ultimately, you have to ask your patient, right? Because we have lots of, and I'll say, having been a regulator, right? We have lots of drug companies that have hundreds of patents on one drug, right? And what does that do is it blocks competition, right? So you can create lots of patents, right? That doesn't necessarily mean it's a great impact. That might fix your bottom line, but I can promise you the patients aren't going to trust you. So it's important, again, that's an important metric to help you monitor, but ultimately, it was Joe, the guy who spoke today, you have to ask.
Grogan.
Yeah, you have to ask the patient. You have to ask who your end audience is, right? What's our purpose? What's the mission? Who are we trying to serve? And if we really are patient-centric, right, who's the patient we're trying to serve? And how does this make them better? How does it help them or in their relationship?
So we have another question here.
Yeah, hi, Pavel Poland. I was thinking in regards to trust, be it in an organization between employers and employees, or between, say, doctors and the community, just members of the community that are using doctor services. We have social platforms, Facebook, Twitter, all that, where people put a lot of trust in them. They basically share all the information about not only their health, their well-being, their everyday lives and all that. So they give a lot of trust to those platforms. What do you think of using these not necessarily those huge platforms, but more localized platforms, so within a health plan or within a hospital, to engage people from, like, say, doctors and patients or employers and employees, to build that trust, to create, like, platforms that would be localized within, say, a community or a organization, to build the trust. So, members of this community, this digital, say, community or platform would be doctors and patients, where they could connect without really sharing sort of, sensitive data, just being there, showing that you're in the community, basically, to build that trust between the doctors and patients or employers, employees.
Yeah, I just feel it's just another tool. A tool is great, but it can be used from inward mindset versus outward mindset. You have Facebook, and I can compare myself to all the wonderful stories that all my friends and vacations that they're going on, and feel like it's terrible. It's just a tool, right? It's not building trust. It's just making me feel bad about myself, right? I think any of the tools are available. It's not a technology problem that we got. It's a connectivity problem we got, right? Who do I trust on social media? How am I going to interact? Be it a text message or something I post or Snapchat or whatever the other things. Who am I trying to interact with? Who am I trying to connect with, right? What's the value that I get from them? Because until we focus not on the tools, right, and what's all the whiz bang, and say, oh, you've got 1,000 likes, therefore there must be 1,000 people that like you, right? But really get back to what's the value to that person of that, right? Who's that matter to? And you have to ask the patient. right? Or the provider in that relationship. So I think any of the tools are there, right? That's not the problem. When you look at our problem, it's the mindset, right? We're not adopting it because we've got all these other resistance factors.
Yeah.
See, but the doctors can't want the trust. They have to trust, right? That's what I'm saying is, I can't want everybody to trust me if I'm not trusting, right?
It's not, and trust is trust is an outcome from having done the right thing. I mean, in a very gross term, it's having that authentic engagement and having aligned with the expectations of that person on the other side of the relationship. You can't go out, I mean, the thing that's also, I think, underestimated sometimes in the system is how smart the patient and consumer is sometimes.
My 5-year-old.
I mean, we did a study, and there's a lot of people who share a lot of information on Facebook. They don't share information on their health. They are still, that is a private
That's why we have, what's the other word? Care Bridge, right? Because the stuff they don't share on Facebook, okay, it's just the few trusted friends.
And it's about what you do that earns you trust, not trust in and of itself. And so it's really about the actions of your organization in alignment with your employees, your mission, your stakeholders. And although I did say the one new stakeholder that I had not thought about until I got to this conference was the U.S. taxpayer as a stakeholder.
Oh, yeah.
Which I heard many times, and I had never got.
That's all of us.
I know. Well, that's all of us, as we are all patients and consumers at the same time. But the idea of segmenting my actions because I'm protecting my taxpayer is one that I'm chewing on right now. Perhaps I should have been in government service sooner. I don't know.
I think there's an important part of value also as you develop that trust. So if you think about doctors and patients and within a hospital communicating about personal health information, that sounds scary. On the other hand, if you look at an organization like Patients and Me, and I was really curious about it, so I've got health problems like everybody else does, so I signed up. And it was amazing to look at the conversations between people that didn't know each other, couldn't really be identified easily, talking about the most critical health issues, intimate things, and other people being intimate with them. And so there was clear trust, but it was valuable enough to people who were searching for some answers, who didn't feel that they could connect with anybody in a trusted way. So they got value and they took a real trust risk, but it was working for them.
But they felt they earned the trust. In other words, they were sharing and they received information.
Correct.
Likewise.
But what's the difference really with an organization like that, which is, again,
exactly
established by patients, to something that might be more part of an organization or a hospital system, or could you ever do that?
Well, Patients Like Me is now owned by United Healthcare.
Yes, I know, but that's a separate question.
Well, I'm saying there are, the integrity of that community, which I have great respect for, is still very much intact. I mean, the question is, I think you used your assessment of the critical authority of that, right, in having that conversation. And so, it doesn't have to be perfect, but if you're delivering something meaningful and of value, I think people will look twice. They will even take that information from a pharmaceutical company or a device manufacturer if it solves a fundamental problem for them.
If it solves a problem for them.
Right.
If it does,
it helps them be better.
And if, I don't know, maybe it's something about another individual talking to a single individual, it's easier to get trust.
Well, that's
having a trust relationship with a device manufacturer, with what they're going to say and what they're going to know and what they may or may not tell you. That's a higher bar, I think.
Yeah, that, having been at the FDA, that's one of the reasons why we put a limit on that type of advertising. But ultimately, the advocacy that you get from those groups, right? It's not necessarily. There may be some folks on the internet, right? Just they'll follow somebody, and that's the person of interest. But I think ultimately, it's going to come from who do they know that's also on the net with them, or who has a similar story, who they ultimately believe, right? Again, I don't pretend like we can actually fix that, right? We don't know who's got an alternate Twitter or whatever handle or Facebook handle, right? But ultimately, it's still going to come back to connection, right? Who am I connecting with, and how does it help me, right? There's a whole community, right? And that's why, like the anti-vaxxers, you brought that up, right? There are folks that absolutely believe that the shot that their kid got caused them to have autism or whatever, right? I'm not going to be able to fix that by telling them, oh, it's just a bunch of bogus, oh, try this, right? Because if they have trusted somebody, then I have to earn that trust before I can, because they have something that they believe. Now, we can keep yelling them in science, right? But that's why the placebo effect, right? There's a 30% placebo effect, right? There's a 20% nocebo effect where some things actually do harm when we think there's no way that they could. So to deny somebody's reality just because I've got data is just me being paternalistic. And until we have that connection, I'm not going to be able to change somebody's belief about vaccines causing their kids problem until I have a trusted relationship with them. Yeah.
So I know we have another question over here.
I was going to do a follow-up on the technology manufacturers, particularly the social media companies, or like Amazon with Echo, who presented here, Google Health, and these are companies that have not engendered trust and privacy,
right.
And they're going very rapidly into the space. And if you follow the money, their monetization is on information and capturing your awareness for a very long time, which is at conflict with what I think is in the best interest for, patient safety, public, security, certainly. How do you? Because they're going very quickly into this space and acting like, oh yeah, no, we've got this, when the history is totally different than that. So how do you address that?
How do you trust it?
No, how do you address it? How do you flip it? Because what I'm thinking of, if you think of how they monetize today, it doesn't paint a very pretty picture for what's coming.
We've also, as physicians, I think we've also created that problem, right? As we have been paternalistic about healthcare for the longest time, and we have lost a lot of the credibility as an organizations group. That doesn't mean, my patient doesn't trust me, but if getting back to your data on how trusted healthcare is, right? So, whether or not Amazon takes it or Google takes it, right? If they're serving a need to the patient, right? Again, this is a system that has many parts that need to be fixed, that can be fixed, right? They're going to fix something, but ultimately, we still have an ability to affect the folks that we're engaged with, right? So if we're worried about the things that are outside our control, it's moving too fast. I don't think the world's going to slow down, right? If we're worried about that and thinking this is not the way it should be, that's great, but that's not going to fix your day-to-day problem, right? You're just worried about something that's maybe outside your control.
But I'd like to just follow up on his concern, because it's not just about will these big tech companies or startups come in and bring a new technology governance model. It's also, they're just being around the edges, influence some people within healthcare to say, oh, I'm going to adopt the Facebook model for move fast and break things. And then you end up in an organization, a healthcare organization, and not just a provider, but a device maker, pharma company, et cetera, where you have parts of the organization that have the old industrial era governance system in mind, and then you've got some people who have the new digital governance model, but it could be from Facebook, move fast and break things, and there hasn't been a sort of agile, middle of the road, well thought out, what works for digital health or healthcare at the pace of digital, but it's healthcare at the pace of digital. The GRC, the governance, risk, compliance issues are handled in a new and special way. Agile GRC I've heard thrown around, but there's got to be some recognition that organizations, when they splinter, and there's these different models for how we're going to manage technology within pharma company X, or it's gonna be a lot of wheel spinning. It's not good. I mean, we got it. How are you going to address that aside from the invasion from outside?
Well, to me, innovation and digital transformation is all the rage, but it's not about technology or products. Because if you are on the path for digital transformation or innovation in your organization or in the industry, and you don't have the culture piece right in the back end, you will end up failing, because people won't be able to, the adapt to the new technology, and they will not be able to use that and then sustain that based on the culture. Without the culture, it's not sustainable. So that's why you again, it goes back to the issue of how do you do the actual, the hard work of setting the building blocks in place in the organization that will foster and catalyze innovation. That goes back to how do you provide psychological safety among your people and then make them feel connected, deeply connected as a team, where you will risk your life for the other person. And then create an environment where learning can spontaneously happen in a self-organized manner. Then innovation is a byproduct. It's a serendipitous byproduct. The worst thing you can do for innovation is put somebody in charge of the Department of Innovation and then give them an office and give some people in budget and go make innovation happen. That's not how it happens.
Yeah. I don't know if I'm answering, or if I'm understanding your question, but I'm just going to say this because it makes me think about change and worrying about. Extinction happens because change is either too fast or too slow. And so if we're worried about people who are going too fast or organizations that are going too fast, they will be extinct. If there are organizations that are going too slow, they will be extinct. But there is a wide range of room in here for us to operate, right, and continue to make, some are incremental changes, some are big changes. I don't pretend to know which is the right one, right? All I can do is know which is the ones that are the right ones for me and the folks that I interact with. But maybe I'm not getting your points clear. Is it more around how to, is it the worry about an imposition of organizational governance, that the rules are being set by somebody else?
In other words, how you framed it. You don't want the organization, teams, resource decisions, risk decisions. On one hand, you don't want to be too fast. On the other hand, you don't want to be too slow.
Right.
And there's room in between. But how do you get an organization to agree on, okay, what's too fast, what's too slow, when you've got some people looking in the rearview mirror of the healthcare industry and some looking to Facebook as the company to copy. And Facebook probably, I think they've lost enough credibility that they won't be looked to.
Yeah.
But I think that's the challenge that a lot of people, and you've got different parts of the organization, and part of it is culture. You know, you've got people who have different cultural backgrounds, and they're coming to these governance issues, risk issues, with different mindsets.
Yeah, and I think, Sunnie, I agree 100% on this one, is you can have lots of cultures within your organization, but there's only one that really matters, right? It's how do folks see each other's? Because you can have your culture of you can have whatever Myers-Briggs type or DISC type or matrix type of groups. You can have whatever ethnic groups. You can have all those groups within your organization, right? But the only culture that matters is how do they interact, right? How do they see each other? Because that's the diversity, inclusion, equity part. Because if all those people are bringing about you by yourself cannot solve the problem for everybody. You cannot be everything to everyone, but you can engage. You're going to find the best solution when you engage everyone within your organization, right? That is your competitive advantage in this day and age, right? It's your people, because the technology is all. Your competitive advantage is your people, and the only way you get the most out of them is by creating a culture that allows for that inclusiveness and allows for that accountability. Folks wanting to be accountable and want to be helped, and if you try to legislate or partition them into certain boxes, you're just putting them in a box, right? And you're now saying, this is your job, your responsibility, and if you don't, you're trying to hold them accountable for it. You can't do that. Well, you can, but it's not going to get you the result that you want, right? I think Sunnie and I are 100% agreement on it's the culture of the interaction, right? That matrix organization, allowing people to flourish, right? Not doing whatever they want, right? But within the structure, within the requirements that you have, that you all educate folks on, right? And say, okay, now how do we solve this problem? Let's work together. How do we engage each other? And don't create resistance to the ideas that are internal to our organization.
So, Ferris, I guess we have one more question, and then I'd like to ask a couple more, if I could. So another question here.
So the last mile of innovation is adoption. And 2 years ago, I had an experience where we were implementing a fairly modest innovation, and we needed 3,000 nurses to all utilize that in exactly the same fashion. And to the extent that they did not, trust was broken because the information was inaccurate for the next user, if you will. And so we had this really interesting breakdown in implementing that innovation that was really important to patient safety. But getting 3,000 nurses to utilize that innovation, and of course has to be done house-wide, system-wide implementation, so it's all got, the agility question, it comes into play there. You need to get all of them to adopt this on a single day and time. So I'm just curious if the panel has any thoughts as to solving that challenge.
I'm happy to jump on that. That's me, right? It's Ubuntu. If you want to go quick, go by yourself. If you want to go far, go with each other, go with others, right? So when you're bringing a technology, you're bringing the tool that says this is what's going to fix patient safety, right? What is that saying? It's that 3,000 nurses, you're doing patient safety, you're not doing it right. Right? So how am I going to, if I'm a nurse in that organization, how am I going to respond to somebody telling me I'm not doing patient safety? Right? Have you thought about what is it the problem that you're really trying to solve for them? Right? So if I'm a nurse, what's Jason's problem as a nurse? Right? How do I feel patient safety? And getting the buy-in is how would I go about solving this challenge that your problem, your solution is bringing? Right? Because if that's not my solution to it, right? Then getting me to adopt it is probably not going to be what I'm going to do first. Right? So, that I think is to me, the overarching theme that I would feel about technology, right, is it is a tool, but until we're concerned about what are the problems and whose relationships we are disrupting, right, until we focus on that, the tool is just a tool. It may get adopted, it may not. Right? It may get adopted somewhat and not be very effective, but unless we focus on what's the relationships and the culture of the organizations that we're entering and our relationship to those who we're asking to implement, we're just seeing them as objects. We're just saying, here, you go figure. It's like the first time I came to a consumer electronics show here, I was walking around all the whiz-bang, and then I'm like, okay, this is a great board. Now how do I use it? And the guy goes, no, you go figure it out. Well, that doesn't help me. Right? It's kind of like the app on the phone. It's like if I don't understand how it's really going to help me, I don't use them. Right?
So I know we're closing in on the time to say goodbye, but before doing so, Ferris, I want to make sure that I handle this in the way that we would do a presidential debate. I'd like to give one last minute each to their questions that you raised when we were talking by email about this is the question that I would like to see. And Lynn, you raised some really good ones. Everyone did. But I'd like for you to, your closing remarks, if we didn't cover one of your questions, present it yourself. But what would you like to share with the group in closing?
Yeah, so change is coming, be part of it. I mean, I'm very, very impatient, and for decades now, the promise of an EHR where I would be able to understand more from a population or solve a problem more quickly has always been sort of teased in my head. I think the incentives are so incredibly aligned from the payer perspective, from the patient perspective, from the system perspective to do something better, that I would challenge everyone to find one thing and go do it and fix it and have that organization engaged around that so that the doing of it better becomes then the hallmark of the culture within your organization. Because I think there's a lot of things we can be worried about, but when we're all focused on the needs of the patient and the communities that we serve, we can find the most unusual solutions in front of ourselves and take that as an opportunity to shine a light and rally your organizations to make that change.
Sunnie?
I would encourage you not to get discouraged on your journey to innovation and start something in your own sphere of control and just start working on it, start producing results and share that it results broadly in the internally with using internal communication. And once you do that, people will start to see they'll catch the spirit, and then as more people will join, it will produce a snowball effect. So don't get discouraged. Just start something and keep working.
So I think what I would want everybody to think about is to think about the examples that I talked about, just as to be inspired by the fact that an individual can actually make a simple decision and have it grow exponentially and become global and powerful. But that along that journey, you need to think about the things that we talked about today. I thought this was incredibly valuable, about trust, about culture, you know, about putting yourself in the shoes of the other person.
Yeah. I would.
Those are probably the better levers.
Yeah, I would just say mindset matters most, and I would really like to connect to all of you. So I'm going to go back to that slide that I had, and this is, I am not the tech proficient guy, but if you're interested in connecting with me, this is one of those smartphone thingies, right? If you put the QR code, it'll take you to a website and just put your your information, your email, and I'd love to be able to connect me, or connect with me on LinkedIn. I'd love to hear more thoughts around how do we fix this? Because this is the great thing, is right, we're all here to fix health.
Ferris, you have the last word.
He does.
I will. I also take the changer just for a second, but let's all give, beginning with Charles, Lynn, and Sunnie, and Jason, and Delise, a round of applause and thank you for a discussion that was well developed and well earned. We will be distributing some of these materials. If Juliana in the back of the room doesn't have your contact information, I know many of you registered, so we have that, but if you didn't, give her your business card or just jot down your information, and we'd love to connect with you. The thing that I wanted to go forward to, join in the conversation. We have launched just this week a follow-up to that HCEG Top 10 that I showed at the beginning. That's the profile from our members on their challenges and issues and priorities. But we're doing a national research now. It'll probably involve about 500 people. We'd like it to be all of you and all of your friends. We will send you the electronic link, but there's a bit.ly link, and there's cards, I think, on your table that have a connection to that. The second thing is that we're going to continue conversations about these priorities. A couple of my board members and I have a session at AHIP's Consumer and Digital Health Forum, which is kind of underneath all of this, in Chicago at the Sofitel on December 10th and 11th. Our session is at 11 o'clock on the 10th, and we'd invite you to join. If you need a discount code for CDF itself, you can email Juliana or go to our website, and the code is there. And then annually, we get all of our members together. There's also a card on your table. Our annual forum is next September in Boston. We'll create the 2021 Top 10 list. The year leading up to that will be conversations like this to get us to whatever the next year's set of priorities are. And then you, of course, can continue to connect with HCEG through our website, through LinkedIn, Twitter. We would just love to keep this conversation going. And as I listened to the conversation this afternoon, I have a sister-in-law who is Navajo. And years ago, she said to me, you never really know something until it falls from the head to the heart. And our hope today is that this conversation has helped concepts that we probably kind of had in our head or up here at the forefront of our mind, but we hope that it's helped each of you to find that falling down to your heart, where it becomes as much of our hearts as it is of Lynn's and Sunnie's and Jason's and Delisa's, so, and Charles. Thanks to all of you. Take time to network with each other, get to know each other, and connect with us. We thank you for your participation today. Have a safe travel home.